CI, any comment? Meanwhile, will you like to comment about late malapposition in acute coronary syndrome and role of imaging and how important this topic is? And second is regarding, you have nicely demonstrated the bifurcation lesion and the wiring across distal versus proximal strut. What's the clinical importance of this particular aspect?
So first question is an malapposition, right? Yes. By angio, we cannot identify any malapposition. It looks very good by angio, but sometimes by imaging, you can identify the malapposition, especially in the proximal site, if you do not do the higher pressure bigger balloon dilatation, right? At that time, I think when patients have some problem, or you try to do the additional intervention, sometimes wire goes just behind the stent strut and make some complication. That might be the problem. So I think it might be better to have a good apposition. Otherwise, there are some risk of the complication when you do the additional treatment or other. Yes.
Dr. Akasaka, especially with the acute coronary syndrome, when you do have now plaque burden and thrombus, which do regress with the time, and with the imaging, though you have demonstrated a very nice result, well apposition across the stented segment, but then later on the follow-up, they are the cases where you do have a late malapposition of the stent struts.
Yes.
Any comment about that particular aspect?
Yes. At the time of ACS, sometimes vessel is a little bit shrinkage, especially the distal to the culprit site. So we speculate a little bit bigger size and try to put the stent a little bit bigger, but too big makes some dissection in the distal portion, and also at the site of a plaque rupture, sometimes the plaque will disappear during a follow-up. At the site, we can identify the lots of malapposition, right? So I do not have any good idea, but during follow-up, if we identify the big malapposition, try to make some apposition by using a little bit bigger balloon. But a perfect apposition is sometimes difficult to obtain. But we have to know there are some malapposition. Otherwise, if we try to do the treatment in the distal part, sometimes wire goes in behind the stent strut, or sometimes wire is very smoothly goes in the distal part, but if you try to push in a balloon or imaging device, it might be very difficult. That may stuck at the site of the incomplete apposition, right? It is okay to your question, right? And second part, I forgot.
It's regarding the bifurcation lesion and demonstration of, say, proximal versus distal strut crossing, and it's a clinical significance.
I can't.
It's a clinical significance of crossing of the distal versus proximal struts in bifurcation lesion.
So, as you rightly said that you cannot control the link-free carina or link carina, that we cannot control when we are doing a provisional stenting. So, so we cannot control it. Number one, there is no clinical evidence that showed that there is benefit of using routine routine kissing balloon inflation. So, what do you suggest? What is the clinical implication of that?
That's right. Yes. During a long-term follow-up, I can identify lots of tissue proliferation at the site of the side branch orifice. So 6 months or 1 year should be okay, but 3 years or 5 years, we can identify the lots of tissue growing at the side branch orifice. And there are multiple side branch orifice. At that time, how to treat? I do not have any good idea. If you try to select the only if you succeed to select this proximal site, and if you cannot select the distal cell, at that time, if you dilate simple balloon at the side branch, a strut goes up to the main branch, right? And then you try to dilate the main branch separately, and strut goes the same position. And even if you try to do the kissing balloon, the metal carina is still there. At that time, it's a problem, right? Yes, as you said, we do not have any enough evidence. So from now on, it is very important to demonstrate by you, because in India you may have lots of crossover technique or two-stent strategies. It is very important. Previously, I think the expert recommend to select the proximal cell in crush technique. But I think in my experience, mid portion is sometimes better to obtain a good side branch orifice. So still there are lots of issues we have to resolve in the future by OCT.
So you rightly said that we in India that we are doing one randomized trial to see whether routine kissing has got any, what is the impact of routine kissing on provisional standing, because there is no answer to it. Though EBC they say that in provisional left main standing go for a routine casing, but that's based on anecdotal case report. There is no evidence in favor or against that.
That's right. That's right. So. Yes, I think try to make and simplify. We do the crossover technique first, right? Because the crush technique is a little bit complex. Therefore, we try to do the crossover single stent technique, and then try to select the distal cell. At that time, if we do the kissing balloon, strut goes to the proximal side of the side branch, and we can get enough lumen area. We speculate that might be the ideal, right? So for but we do not have any data of the long-term follow-up. We have to do that, right?
If there is no further question, thank you very much, Dr. Akasaka, for a nice talk.
Yeah. Is the imaging is helpful in finding out the culprit artery in non-STEMI? Because most of the times we are extrapolating the STEMI findings to non-STEMI. Is it anyway any helpful imaging?
Yes, it is very important. If angio is enough, we can easily identify the culprit vessel and culprit site. But sometimes you identify as a troponin increase and angio demonstrate no significant lesion. At that time, expert highly recommend to use an imaging, because we can sometimes identify small rupture or the erosion with thrombus. So imaging is very important to identify that is actually the ACS or not. Is it answer to your question?
No, these are only for STEMI. I'm asking for non-STEMI.
Non-STEMI, yes. Same condition. Non-STEMI, we cannot, sometimes difficult to identify the culprit site, right? Therefore, if you diagnose the ACS in the patient and angio demonstrate no lesions, try to do the imaging to identify the culprit site.
Yes, Dr. Akasaka is the co-investigator of combined intervention trial, and in this particular study what we are investigating to look for the non-culprit vessel and a thin cap fibroathyroma and the plaque rupture are the one which can very well give an idea about which the culprit vessel is.
Yes, yes. In case with, yes, no, even in STEMI or non-STEMI, if you identify some disease in the other vessel, try to check by imaging. There are a lot of small rupture or disruption. At that time, I highly recommend to treat such lesion. It is very important and useful, Right.
Thank you, Professor Akasaka, for a very
you.
nice talk. Now we'll break up for coffee break and then we'll rejoin for the panel discussion.
Thank you very much.